begin, brothers and sisters. I'm Greg Albo from York University Political Science and one of the co-editors of the Socialist Register. Leo Panich, who was supposed to chair this evening, is not available. He was called away to Ottawa on a family emergency, so I'm filling in for him chairing tonight. Besides the Socialist Register, there's a number of sponsors for tonight. The York University Bookstore, which is and Fernwood Books, which are selling copies of the new Socialist Register at the back. Also the Socialist Project, which is a number of publications, Relay, and a number of the bulletins, including a pamphlet on the crisis in healthcare in Canada at the back. The second transition is a little bit more difficult. It's a transition in the editorial structure. Colin Leys, sadly, is resigning as one of the co-editors. Sadly resigning was one of the co-editors with Leo Panich after many years, and after, how many years was it? 12 years. 12 years. He is being replaced. Of course, it'll take two of us to fill Colin's shoes. He's being replaced by myself and Vivek Chipper, who will take over the editorship next year. So this volume is partly a topic that has been partly a climax to Colin's years as editor, because healthcare for the last decade has been a major part of his research on privatization and neoliberalism, as well as some of the more specific work on the National Health Service in Britain. There's a range of innovative essays, which Colin will speak to in a minute, on accumulation in the healthcare system, the fights over privatization, looking at it in different places, the differences between Cuban and the trajectories of Cuban healthcare and the Chinese healthcare systems as they've both transformed under actually existing socialism, and so on. So there's a range of very exciting essays in the volume. On the panel to present some of their work, Colin, as the editor, has a spectacular essay, I think, on analyzing a whole range of issues related to healthcare under capitalism. I think it's just a very, very fine essay, which has been being noted very widely by wide numbers of people, both activists in the healthcare sectors, doctors, intellectuals who are teaching healthcare issues, and so on. He'll speak to the volume. Enough of me. I'm going to turn it over to Colin, so Colin can introduce and speak to a range of the issues in the current volume. Colin.
Okay, my job really is to commend this volume, and I don't think I can do it better than Greg has just done. We could have been thought when we started planning this 2 years ago to be missing the boat, because, you know, just as we started to think about health, which is a long-term ongoing thing, the capitalist system went into freefall. But actually, as Greg said, it really proved the point that everything in the end is measured in terms of health. In fact, in the essay on Cuba, Julie Feinsilver makes the point that the Cuban government has always measured its economic and social success in terms of its health statistics. And of course, this doesn't happen in capitalist societies like ours, and it should. So let me just commend the volume to you not in the way Greg did perhaps, but let me just say that I think it's a great volume. I think the coverage is remarkable. Leo wrote the back cover blurb, and Leo Panich. And I think it's a model of how to do it, and so I'm not going to repeat all that. If you haven't bought the volume, or at least 2 copies, you should get it before you leave and read at least the back cover, which will give you a very good summary of the argument of the book. But seriously, I think it is an exceptional book, though I say it myself, in a number of ways. First of all, it makes very firmly the distinction between health care and health. I'll come back to that in a moment. Secondly, it foregrounds not the health services that we have, which 9/10 of books on health policy do. It foregrounds the enemies of the health services we have. That's to say, the corporations across the world, heavily based in the United States, but by no means confined to it, which are seeking to undermine and erode and take over the health services we have. And I think the combination of this with the global reach of the essays in the book makes it different. I think I certainly don't know of any other book in the field. I think if you're interested in having a handbook to frame these issues as we enter into the threatening period that we are going into for health services, it's a really good start. And though I say it myself, I think it's a good read. It isn't a laugh a minute, except for the title. But it's quite a page turner once you get into some of these papers. Let me just say about the importance of distinguishing health from healthcare. Much the most important determinant of health is social and economic policy. Progressive doctors have always understood this, that treating their patients when they're sick is secondary to the social policies on which much of their sickness, from which it stems. A founder of this tradition was a brilliant German medical researcher, whom some of you undoubtedly know about, called Rudolf Virchow. He was a contemporary of Karl Marx and Friedrich Engels, and he was on the barricades in Berlin in 1848. And for his pains, he lost his job and was sent out of Berlin to practice in some justly ignored provincial town. But he was too clever to be kept out for long, and after the immediate reaction against the revolution, he came back to Berlin and eventually became the leading voice in German health policy making. And he summed up the relationship between health and politics in a famous phrase, which I read because otherwise I'll screw it up, brief as it is. He said, medicine is a social science, and politics is nothing else but medicine on a large scale. I think this is something worth thinking about. Not too many doctors, not all doctors see it that way, but there is a strong tradition of doctors who do. 5 doctors are included among the contributors to this volume, and we have another one here tonight, Andy Coates, who will speak to us shortly. It's one of the important points to bear in mind when we campaign for the defense of healthcare or its extension where it's lacking, that without the doctors it can't be done. And so this current of medical thought is crucially important. In most of the world, however, in all the OECD countries, public policy is not aimed primarily at making us as healthy as possible. A huge amount of ill health could be eliminated by appropriate economic and social policies, and isn't. And this is very clear in the case of some very poor countries, such as Cuba or the state of Kerala, which have good health statistics but low incomes. Most governments, like ours, prioritize growth and the advancement of corporate interests, even when this means declining health. Rob Albritton's essay, which Greg has referred to, about obesity and hunger, shows this very clearly, how basically the interests of the corporations in the food industry have a higher priority than the health of children. And the same is true for the alcoholic drinks industry. So the crucial dimension in public policy in relation to health is equality. The more neoliberal public policy is, the more inequality there is, and the worse the health is. In the United States, if you are born into one of the poorest and certainly into a black community, your life expectation is roughly 20 years lower than that of a rich child born into a white community, or a rich white community. Same in the United Kingdom, which is following close on the United States in developing massive inequality under neoliberal policies. In the city of Sheffield, Danny Dorling recently discovered that the life expectancy difference between the poorest part of Sheffield and the richest is just under 18 years, and that has widened dramatically within the last 5 years of the Labour government. And life expectation itself is in some ways a very crude and abstract measure. It doesn't measure the misery, the pain, the impoverishment, the humiliation, and the family suffering that those life differences, life expectation differences reflect. It's interesting to think when you know that the average life expectation is around 80 years in countries like the UK, that what that figure means is that if you're born in the wrong part of Sheffield, you won't draw a pension. Right? So a cynical way of thinking about this is if you don't do anything about health inequalities, you reduce the state pension bill. Okay, now to think about health care as opposed to health for a moment. A very basic point which many people here are familiar with, but forgive me if I re-mention it, is that before the 1940s, doctors were really not able to do very much. In the 19th century, you were in some respects better off if you didn't go to a doctor. Doctors could kill you by inappropriate treatments because so little was understood. And it's hugely significant that when a range of treatments for a whole range of illnesses, of infectious illnesses in particular, became available, really generally became available during and after the Second World War. That coincided with the peak of the power of organized labor in so much of Western Europe, and to some extent in North America. As a result of which, when treatments became seriously interesting, the working class was able to demand electorally that they got it. Even the United States was obliged eventually in the 60s to introduce universal health care for retirees and for the very poor, Medicare and Medicaid. Where that didn't happen, more typically in countries where some provision was introduced, but where structural adjustment programs in the 90s broke them up again, destroyed public health care systems, the lack of health care can be enormously significant. The figures can be appalling. A good example of this is discussed in an excellent paper in the essay on maternal deaths in Africa. In OECD countries, fewer than one birth in 100,000 leads to the death of a mother. There is a mortality risk, but it's less than 1 in 100,000. But in sub-Saharan Africa, the figure is almost 1 in 100. And the lifetime chance of a woman in sub-Saharan Africa dying in childbirth, and that's to say, bearing in mind that a woman will have several pregnancies, her lifetime chance of dying in childbirth is 1 in 26. And in the worst case currently recorded, Niger, her chance is 1 in 7. And this appalling fact is entirely due to the absence of appropriate health care. And that's not just a fact, that's due not just a consequence of the general lack of health facilities, it's the fact that such facilities as there are biased against pregnant women. And that's very interestingly discussed, and it's one of many examples that could be given, but I think it's the strength of the volume that it foregrounds that dimension of healthcare in the global south. What's worse is that global health policy has also been captured to an increasing extent by global corporations. The Bill and Melinda Gates Foundation has a larger annual budget to spend than the World Health Organization by quite a long way. And the World Health Organization's budget is and always has been heavily dependent on discretionary giving by a variety of sources rather than dues submitted on a per capitation base by the member states of the United Nations. The way global health policy has been compromised in the last 10 or 15 years by its penetration by corporations is spelled out in a very good essay by Mary Koivusalo, who's a distinguished authority in this field and a doctor in Finland. But even in countries like this, and certainly in the United Kingdom, universal health care is now seen by business and increasingly by politicians as a field of capital accumulation from which, unfortunately, in the post-war years, capital was excluded. And their aim is to undo this. We've watched the medical, insurance and pharma industries in the United States successfully blocking yet another attempt to make healthcare universally available in the US, even though a clear majority of American voters say they want it. And a remarkable essay in the volume by Marie Gottschalk explains the background to that, and we'll hear the outcome of it in a moment from Andy. And where universal health care already exists, the capitalist health industry works hard to turn the clock back, cutting back on public services in general, including health, and turning them over to for-profit providers. One of the most, to me, depressing stories is told in a very cogent piece in the volume by Christoph Herrmann, who many of you here know, in a survey of what's happening across Western Europe in the rollback of universal health care in corporate interests there. I think Canadian healthcare is threatened too, and no doubt Natalie will be talking about that. In spite of the massive endorsement of the healthcare system here, the alleged need to cut the fiscal deficit has given the right everywhere, a new rationale for seeking to cut back on universal healthcare provision. In effect, to stave off a disaster created by capitalist greed, workers in general are being asked to sacrifice their right to public services, including healthcare. Only very determined resistance is going to prevent that happening. And the work done by the Ontario Health Coalition to resist these pressures is brilliant. I think it's going to need a lot more additional resources than those it has enjoyed up to now, and I hope discussions like tonight's will help make that available. So, to sum up, health and healthcare are at the heart of what's at stake in the bourgeoisie's intensifying drive for global domination. It's a fundamentally socialist issue. Like any policy, it has its complexities, but they're not impossible to understand, and the aim of this book is to make them straightforwardly accessible to anybody who's concerned. We need to know enough about it to see what's happening and to assert our right to health as a key dimension of our right to equality and freedom from exploitation. I hope this volume can play a part in making people see this. So please buy a copy and one for your friends, and tell everybody else about it too. Thanks.
Thank you, Colin. Typically of Colin, he didn't speak as much to his own essay as I might have wanted. I just wanted to point out something in his essay, that it's a remarkable analysis of tying together his interests, longtime interests in Africa and Britain, and attacking the proposition that capitalism promotes health, which has been the theme particularly in development studies of the World Bank. Its approach to Malthusianism. It's also viewed that capitalist development equals health. And it's an amazing essay that unpacks those propositions in detail and develops the distinction he made between health and healthcare and its particular relationship to capitalism. Well, next speaker will be Pat Armstrong, who's obviously, as we know here in Canada, has been integral to the struggles to preserve Medicare and dealing with privatization. Not only has Pat Armstrong's work with her partner, Hugh Armstrong, been absolutely important to these struggles, it's been very innovative, I think, in the way it's not only addressed the issues of privatization, but the way it's also taken on questions of work inside the healthcare system. Particularly, I remember hearing some of her essays when her and you began doing the research in the late 80s, maybe, and you were beginning to do the research on the way total quality management was being applied in the healthcare system, and there were all these attempts to kind of measure what was a quality management heart surgery and these things. It was an amazing bit of research and absolutely humorous presentations. Pat continues on with that with her essay in this volume, which takes up issues of work in the healthcare system in Canada in particular. Pat.
But not very humorous. Natalie was reminding me tonight at dinner of a story about security guards who every night would stop a construction worker leaving a construction site because he was pushing a wheelbarrow that was piled high and covered with a tarpaulin. And they would make him take the tarpaulin off and find garbage underneath, and that they were sure he was stealing something. But when the construction was finally done, the security guard said to this guy, "Look, you know, we know you've been stealing something. and we promise we won't follow it through. Just tell us what you've been stealing. And he said, wheelbarrows. And I think of it because, of course, that's what they're doing in terms of our healthcare system, promising us to save it and stealing our public care as they do it. There are 5 central points that we try and make in our paper on the labor force. And I just want to go through, in my 10 minutes, those 5. The first is that context matters. While there are certainly global pressures from capital and neoliberal strategies that are being played out in the healthcare labor force, as Colin makes so clear in his introductory essay, there are also historical conditions and relations that shape the specific situation and responses on various scales. Canada is not so much special as specific, as are all jurisdictions. And we focus on Canada to both illustrate our other 4 arguments and to demonstrate the specificity. Our strategies must be both global and local, as I'm sure is obvious to everyone here, in ways that take both into account. And that's what we try and do in this essay. Our second point is that healthcare matters. We argue that healthcare is indeed a special case, that we need to understand the particular nature of healthcare services if we were to understand the conditions and relations so we can change them, which of course is, I think, what we all want to do. It's about life and death as well as about regular irregularity. The nature of healthcare work places particular kinds of limits on neoliberal strategies. It allows particular kinds of struggles and methods of control on behalf of both managers and workers. And I think we have to remember that it offered both. It provides for particular forms of resistance. It's hard to imagine that a Teamster could get the kind of public support experienced by healthcare laundry workers in Alberta, or that public sector transit workers would have the popular rallies for personal support workers that we saw in Manitoba. Our third point is that definition matters. In defiance of the evidence on the determinants of health that Colin was just speaking about, and on the specificity of care that I was just talking about, half the labor force is being defined out of care. The division of labor and health services has grown as a result of both managerial strategies and worker struggles, carving off many of the jobs previously done by nurses to be done by those often called ancillary workers, and increasingly defined as providing hotel services. The definition has supported both the privatization and the de-skilling of the work, which evidence increasingly shows us contributes to the breakdown of teams that Andy and I were talking about just before dinner, as well as to a general deterioration in care. We need to put these workers back into the healthcare labor force, in theory as well as in practice, if we're to support decent public care. Our fourth point is that gender and racialization matter. Women account for the overwhelming majority of healthcare workers, paid and unpaid. We cannot understand the forms of their struggles or the responses to them without understanding that these are highly gendered. As feminists have long made clear, understanding the conditions of work means looking at both production and reproduction, understood as the daily and generational reproduction of people. The shedding of care work to be done by unpaid providers in the home, for example, is largely based on the assumed and too often enforced work of women. And we cannot understand the dismissal of ancillary work as unskilled hotel work without beginning with the racialized and gendered labor force that does this kind of work. Fifth and finally, contradictions matter. And that's what the title is all about in this piece. As we all know, our focus needs to be not only on the historical and material, but also on the dialectical. Within health services, it's important to understand how health workers' struggles have often had contradictory consequences, not only for the group that makes the demands, but also for other workers in the same kind of labor force. The struggle for evidence-based medicine, for example, grew out of doctors' efforts to improve care and was enthusiastically adopted by many nurses' organizations because it seemed to be a way to not only improve care, but also to enhance the prestige and power of nurses. Evidence-based medicine also seemed to offer them some ability to act autonomously to resist doctors' orders. But those same evidence-based approaches are being used to increase managerial control and support technology designed to replace workers. These then are main assumptions in that frame our piece in this wonderful book, I think. And if you want the juicier bits or the nuances, you'll have to buy it, as Colin said. Thank you.
Thank you, Pat. We'll now turn to Roddy Loepky, whose essay in the book looks at accumulation in the health sector, and he has in there a little quote I've been using every once in a while in teaching and other things, wealth and health, as the way of talking about accumulation in that sector. Roddy's research in this area, I think, is extremely innovative, and you should pay attention to it. And read also his book on the Human Genome Project. I think he's providing a very interesting alternative to the kind of biopolitics of Hart and Negre and following Foucault, and looking very concretely at what it means when you think of the human body and the health sector as a zone of accumulation, and developing really remarkable ideas and themes about the health sector and the human body as a zone of capital accumulation, which he develops in his essay in this book. So I'll turn it over to Roddy.
I think I'm going to get a quick lesson in why a musical career was never in the offing for me. First, I want to thank Leo and Colin for getting this. Not very experienced with microphones, sorry. I want to thank Leo and Colin for getting this volume out. As somebody who teaches in health, I'm sure Pat can back me up here, it's very hard to find volumes that are, on the one hand, from beginning to end, critical. Is this okay? All right.
It's a mic for singing too.
Yeah. It's hard to get volumes that are critical from beginning to end, and it's even harder to find volumes that are political from beginning to end. So this is a real achievement that Colin and Leo have put forward here, and they're to be commended for that. It's clear enough, I think, that there are widespread popular concerns. I think we have empirical evidence and anecdotal evidence to that end, that there are popular concerns over practices across the health sector. And these relate to a series of issues. First of all, the seemingly endless growth in the costs of health provision that governments are concerned about, as are populations. Secondly, the structural integrity and the survivability of healthcare systems. And third, the legitimacy of privatized service, where debates around market efficiency and greater involvement of the health industry evoke rather strong reactions on all sides of the political spectrum. My little contribution to the Register, isolates just one dynamic, I think, of the private health industry, which I call institutional adaptation. And it highlights some of the ways in which this adaptation furthers industrial strategies of accumulation and growth across the industry. Along these lines, I think there is undoubtedly a ceaseless drive to expand profit margins throughout the industry. But there is also a parallel trend of pragmatic institutional adaptation. The industry is particularly adept, I think, at harnessing prevailing or emerging political and institutional conditions in ways that channel benefits to itself. Can I just get a little water? On one level, I think the industry can't help but benefit from a global health spending level that has surpassed 4.5 trillion US dollars per year, 2 trillion of which occurs in the United States alone. It's good I have Greg here. This is very nice. Could you stand actually right here? Within 6 to 11 years, US health spending is projected to be at 20% of the gross domestic product. So there are really few, probably no industries who can tap into this kind of gargantuan spending stream as exists for the health industry. And health industry advocates protect this privilege with a outright ferocity. On another level, the health market is a very unique market, and profit-taking can be vulnerable to political attack, and it can be vulnerable to accusation. And in this way, the industry assumes nothing. They're very careful to struggle for an optimal institutional environment at every turn, fending off any negative image that may be projected in terms of excessive greed. So in instances where market competition or some reasonable facsimile of market competition is the objective, dismemberment or dissolution of regulatory control becomes the order of the day for the industry. At the same time, where dissolution of social structures or social protection proves politically unviable, industrial advocates will very quickly duck below the radar and usually act behind closed doors to optimize what is otherwise a less than advantageous situation. We're seeing, again, an example of that in the United States. This pragmatism requires a very active and ready industry, prepared and able to intervene in institutional environments at a moment's notice. And no industry does this better than the health industry. Here, a battery of corporate figures, trade associations, medical societies, and privately supported public institutions stand ready to struggle in the name of private accumulation streams in both health purchasing and health provision. And what my paper tries to do is just point to 3 areas in which this institutional adaptation manifests itself. So I want to say something fairly brief about each of these. But since both of the other presenters went so quickly, maybe I can take a couple extra minutes. The first area is within biomedical, what I call a biomedical research and production frenzy. The responsibility for which really has to be laid at the feet of the pharmaceutical industry more than anybody else. Big Pharma re-energized itself in the early 1980s, and it did so under the guise of a biotechnology revolution, a so-called revolution. And this revolution has laid the basis for an all-encompassing drive to extract value, real or imagined value, while ostensibly bettering all of our lives. Since the onset of this revolution, bountiful discoveries are said to be right around the corner, and that's been true for at least the last 3 decades. It's this quality of care that putatively will be rendered by such discoveries that is used to justify the exorbitant costs of the the exorbitant prices of the pharmaceutical and advanced medical technology industries. Put differently, a revolution has bettered our health, and if we want the revolution to proceed, we're going to have to pay for it. And industry advocates claim that profit margins somewhere in the area of 15 to 20% ought to do the trick. In view of these uncritically accepted research cost figures that are put forward by the industry, infrastructural support has been the primary demand of a growing and dynamic biomedical industry. Dependent on a complex and interrelated set of information technologies, the health industry has reached deeply into publicly financed spheres of research and development. And with ample research and regulatory support from the state, this has forced open access to mental labor and defrayed corporate investment costs. In my own work, which Greg mentioned not very long ago, really marveled at the allocation of $3 billion to what I then called an infrastructural human genome project. But now that work seems incredibly naive, not too many years later. The US state's desire to feed health-related research with a mandate for public-private cooperation continues to grow at an astounding rate. NIH, or the National Institutes of Health, backed research exceeded a remarkable $29 billion in 2008 alone. This story, of course, can be repeated for a large number of OECD countries and some select non-OECD competitors, including, but not limited to, Canada, Germany, the United Kingdom, France, and India. The outcome of this kind of public-private partnership in research and production also gives rise to public-private pressures to expand healthcare markets. And that's the second area of institutional adaptation that the industry is particularly adept at. In fact, healthcare delivery constitutes, in my mind, the biggest pressure point for the entire health industry. Obviously, configurations of healthcare vary enormously from region to region, and this necessitates an industry response which is sensitive, that optimizes each institutional terrain to its benefit. In the United States, where the institutional sand seems most often to be shifting, The capacity of industrial advocates to shore up private delivery has been an impressive, if incredibly callous, political achievement. The dynamic strength of US private delivery can't be underestimated, pushing health spending to well over $7,000 per capita per year. US health insurers have clearly opted to exclude the most vulnerable portions of the population, keeping their prices high and dumping risk on means-tested public delivery systems. Moreover, keeping purchasers and providers parceled out has meant that any serious concern for cost leverage has been largely avoided. In terms of quality, embracing the industry's innovation equals better health equation goes largely unquestioned. In a context where innovation is said to supply the best care money can buy, refusal to cover innovative care, in quotation marks, is not good advertising for any insuring agent. So no agent then professes enough leverage to either lower dramatically the cost of provision or to impose universal decisions about which treatments and or products are medically necessary. As a result, cost containment takes place through other means, through administrative pursuit, chasing down patients and minimizing benefits. In this decentralized context, piecemeal reform, including the current round of reform, becomes highly vulnerable to the adaptive strategies of industrial lobbies. Despite the demonstrated popular support for universal care in the United States, the Medicare Plus Choice Act of 1997 or the Medicare Modernization Act of 2003 are very representative of the kind of reform that gets massaged by industrial lobbies. The former aimed to funnel Medicare funds through private firms, while the latter encouraged spotty drug coverage for seniors through for-profit channels. Most importantly, the latter act explicitly disallows any use of federal bargaining leverage to reduce drug prices. Current reform, anticipated well in advance by both insurers and the biomedical industry, has done much the same. It begrudgingly expands, even mandates, coverage to a wider segment of the population, but it leaves the basic parameters of that coverage untouched. Incursions, I think, of this nature in other solidaristic healthcare systems are in no way guaranteed. But one thing I think is certain: what is ineffective in progressive American healthcare reform, incrementalism, could prove devastating to universal care systems elsewhere. Tinkering can, over time, maximize private actors' opportunities to both finance or to provide, even if that happens alongside universal delivery systems. And across Europe, I think Herman's essay points this out very well, one detects varying attempts to divide or make autonomous healthcare purchasers, whether in public, private, or in hybrid form. The danger signs in these experiments of diminished cost leverage and problematic national and regional health planning would only be exacerbated with increased private involvement. And also Colin's work on treatment centers, I think, point to this very well. Finally, regulation is one more area in which institutional adaptation is unmistakable. Here, corporate, state, and academic actors appear slavishly devoted to the idea of a corporate-friendly regulatory regime. The US, again, leads the way here, not just because it's a market system, but because the Food and Drug Administration is held up as a gold standard against which other review agencies model themselves. But in fact, the FDA exemplifies just how blurry the boundary between state regulation and industrial advocacy can become. The Prescription Drug User Fees Act, a beacon of regulatory capture, requests from corporations a user fee for their drugs and biologics approval applications. And this act has been heralded, lauded in Congress as a source of patient well-being, regulatory streamline, and most importantly, a boon to US competitive practice. FDA officials brag that the User Fees Act has fostered the fastest approval times in the world, with added benefit of stealing market share from European competitors on medical products. Left out of this commendation are the hard realities of extreme regulatory pressures to approve. One report talks about a sweatshop atmosphere in the FDA, failing or problematic drugs, overprescribed or falsely prescribed drugs, lax regulatory pursuit on direct-to-consumer advertising, weak reporting of data and adverse reactions by corporations, and the general misuse and abuse of phase 4 clinical trials. So in the regulatory context, it's very fair to say, I think, that speed kills. That other countries, including our own, Canada, continue to model their regulatory behavior on the evolving practices of the FDA does not bode well for patients. While industrial advocates love to characterize review agencies as obstructive, in this case they have become, in fact, finely tuned instruments of industrial legitimization, over which corporate actors would not willingly relinquish their influence. So, in conclusion, efforts to open up health systems, I think, to increase corporate access and industry involvement give rise to a number of difficult questions, but one in particular: how much health is enough? For all their problems, publicly oriented research, healthcare, and regulatory systems make important societal choices about human need that prioritize on some level, on one level or another, social consensus over accumulation potential. The difficulty is that the very effective strategies of the health industry have worked ingeniously to blur the lines between private and public objectives. The various components of the health industry enjoy the luxury of self-identifying as social actors who are first and foremost in the business of meeting human need, obscuring the reality of their enormous returns on investment, and being able to represent these when they are noticed as being of secondary importance. It is difficult, after all, to be against the pursuit of health. In this milieu, the push to expand health spending, to realize profit on the full array of corporate, state, and institutional health-related investments can only intensify. The fact that OECD countries, in particular, bet on health as a growth sector of the future will mean no shortage of protagonists at all levels of this process, from universities all the way up to the World Trade Organization. And this is why universal health care remains a highly significant political project, as a check, a kind of bottleneck, on the industry's imperative to commodify, to medicalize, and maximize profits in an ever-expanding domain of health delivery. Thank you.
Thank you, Roddy. This is a good moment after Roddy's presentation in pointing out the struggles over privatization and medicalization to note that this is also a fundraiser for the Ontario Health Coalition, and Natalie and others are at the back hoping to raise some money. Are going to pass the hat. We're going to take a 10-minute break so the comrades can get a beer and refresh or take a few minutes, and then we'll have up Natalie and Andy Coates to speak about the healthcare struggles and also some of the themes in the volume. So we'll take 10 minutes.